are live now.
Good evening from East.
Yes, Rahul, count down the.
Sir, we are live now.
Okay.
Thank you so much and welcome all of you to this EIZOC monthly webinar on ophthalmology resident teaching series. The episode number 31 we are going to witness today. And for this, we have an eminent speaker, not only national but an international speaker in Dr. Santosh Hanawar, who also happens to be the Honorary Secretary of All India Ophthalmic Society. The webinar will be moderated by Dr. Sramishta Behra, and in the panel we have eminent ophthalmologists Dr. Deepak Mishra, Dr. Randhir Jha, Dr. Chandana Chakrabarti, Dr. Martin Pudle, Dr. Raghuraj Hegde, Dr. Shefali Chahar, and Dr. Devkant. I must express my gratitude to Dr. Ajit Mahi sir, who has been the mentor of this program, and he has been continuously pouring in his valuable time for this. And also to Dr. BNR Subudhi sir, the chief coordinator of the program, for consistently having done this program throughout the year, not only this year, but for the last several years. I'm also grateful to Dr. Jayanto Barua sir, the President-elect of EIZOC, the Honorary Secretary, Dr. Swaraj Bhattacharya, and the Chairman Scientific Committee of EIZOC, Dr. Sabyasachi Patnaik. And with us today, we have postgraduates and residents from different medical colleges, not only of the East, but from other places of the country as well. With these words, I welcome you all again. I welcome the audience with one information that we have the EIZOC annual conference, which is coming up on the 29th, just 3 days later, on 29th, 30th of November and 1st of December at Kalimpong. All of you are invited. Don't miss the opportunity, not only to see the scenic beauty of Kalimpong, to participate in science also. With these words, it's over to you, Dr. BNR Subudhi, sir.
Thank you, President. Now let me start. Visible?
Yeah, not visible, sir. Your slide is not visible.
Now? Now? It's okay?
No, sir.
Okay. Now I think it's visible.
Yes.
It is visible now, sir. You can go to the slideshow.
Yes. So, respected President EIZOC, Dr. Pranab Ranjanji, and incoming President Dr. Jayant Barua, and our mentor Dr. Ajit Babu, and of course Chairman Scientific Committee Dr. Sabyasachi Patnaik, and all the panelists and posted students and with our today's speaker Dr. Santosh Hanawar, I welcome you all to this program, EIZOC ORTS 31 program. This is Ophthalmic Residence Teaching Series program. As our President already told, we are continuing this program since last few years. And today, really one of the national international speaker today we have, and we love to hear from him hours together. So definitely today and also next month also we'll be hearing him. And today's topic definitely is one of his favorite topic, the retinoblastoma. So I think we'll give an overview of retinoblastoma in short time of 1 hour. And today's chief coordinator myself and speaker has already told, and our moderator today, Dr. Sharmishta Behra, will be introducing him. So I don't want to go into details, but he is well known to all of us. Every nook and corner of India, He knows Dr. Santosh Honavar for his dedicated work towards the IJO and giving sight to a lot of retinoblastoma children. So today's moderator is Dr. Sarmishta Behra. She is the professor at Vimsar Medical College, Burla. And today panelists already, Dr. Pranay has already told, because we got a lot of panelists today. Dr. Deepak Mishra from Banaras, Dr. Randirja from Patna, Dr. Chandra Chakrabarti from Kolkata, Dr. Marian Paul from Kochi, Dr. Raghuraz Hegde from Bangalore, Dr. Shefali from Hyderabad, and Dr. Devkan from Patna. So they are the panelists. I think they will be doing a lot of discussions today. So we should have more time today. We'll see if we can adjust the timing today. And discussions, as I told you, today there are a lot of postgraduate students from all over the country, including the eastern states, Dr. Mohan Raj and Dr. Akshish Kumar from AIMS Patna, Dr. Subhasri Sir, Dr. Ankita Mishra from MKC Medical College, Berhampur, Dr. Lakshmi Shaju, and Dr. Shravani Sarkar from Silchar Medical College, Assam, Dr. Sauvika Behra and Dr. Pankaj Shukla from Raipur, JNM Medical College, Dr. Archana Singh and Dr. Sudeep Kumar Dalai from SC Medical College, Cuttack, Dr. Jai Dakshini from Ruby Eye Hospital, Berhampur, and Dr. Saptarshi Mukherjee from BS Medical College, West Bengal, and Dr. Ranjita Amantya and Gurudev BC from Vimsar, Burla. So we got more than 15 PG, 14 PG students, and more other PGs are also already joined in this webinar. So I welcome you all to this program. So without wasting much time, now I thank you everybody for joining this our program, and we will be continuing in future too. Our president will give farewell to today's president, our Dr. Pranav Ranjan, and of course, but we request him to be present with us in future too at the immediate past president. So now it is over to Dr. Sarmishta Behra, our moderator today's program. Dr. Sarmishta, it is over to you.
Thank you, sir. It's an honor to introduce Dr. Santosh Honavar, sir, to all of you. Everybody knows Dr. Santosh Honavar, sir. Maybe he's the only Honavar whom we know so very well. So he received residency training in ophthalmology, followed by a senior residency in ophthalmic plastic surgery and ocular oncology at Dr. R.P. Center for Ophthalmic Sciences, AIMS, New Delhi. He was trained in ocular oncology and mentored by Professor Jerry Shields and Professor Carol Shields at the Wills Eye Hospital, Philadelphia. He established ocular oncology services at LV Prasad Eye Institute, Hyderabad. And as the Associate Director of LVPI, he headed patient care services and established the residency program. Currently, Dr. Honavar heads the Department of Ophthalmic Plastic Surgery and Ocular Oncology at the Center for Sight, Hyderabad. And all the residents are very fond of and are very well aware about iFocus PG education program, which is run by him and is hugely popular with over 2 million views. As the editor of the Indian Journal of Ophthalmology, he was responsible for its soaring impact factor from 0.83 to 3.1. He is currently the Honorary General Secretary of AIOS. With ocular oncology as his research focus and over 400 indexed publications, he tops the Stanford list of researchers of the highest impact in India. Some of the major awards and honors to his credit include Colonel Rangachari Gold Medal by the AIOS. He was the youngest recipient while still a resident. Dr. Shiva Reddy International Award by AIOS. Shanti Swarup Bhatnagar Award by Government of India. Jerry Shields International Award by APAO. He also received the Lifetime Achievement Award by the American Academy of Ophthalmology and the highest award for the Royal College of Ophthalmologists, UK. Its honorary fellowship, both the first time for an Indian ophthalmologist. Thank you so much for being with us, sir. Over to you, sir.
Thank you very much, Sharmishta, for a very elaborate introduction. And I thank EIZOC for this wonderful initiative. I think it's really laudable that you have chosen to take care of the postgraduate training as well by doing this virtual education programs. And of course, Ajit Babu, the mentor of the program, for his kind invitation. So I'll be speaking on a topic which I really like to speak on, that is retinoblastoma, and take you through the diagnosis and management aspects mainly. Why should anybody know about retinoblastoma? Of course, it can come as a major question or a short note in the exam. You may be asked about it in your practical examination about leukocoria and its differential diagnosis. You may get a specimen on your spotter or OSCE, but all that is fine. But apart from that, you should know about retinoblastoma because it is the most common intraocular malignant tumor in children. And it's a deadly tumor with a potential for up to 50% mortality if it is not recognized early and treated appropriately. And it presents to an ophthalmologist first. So we have a privileged position of diagnosing retinoblastoma when a child has an early tumor. Child may come to you with strabismus or inability to fix. That may be the complaint with which the parents bring the child to you. And if you don't look at the fundus, you may miss the diagnosis of retinoblastoma. And the most important aspect is that if we detect it early, it is nearly 100% curable, not in just in terms of salvage of life, but also in terms of salvage of the eye and vision. India has a hot spot for retinoblastoma. India has very high incidence of retinoblastoma as compared to rest of the world, mainly because of our high live birth rate. And if you look at this data, you realize that about 70% of children with retinoblastoma undergo treatment at primary or secondary centers where only enucleation is possible. And with that, an estimated mortality is 30 to 50%, and we have a chance to reverse that. This is one slide that depicts the change that has, or revolution that has undergone in the management of retinoblastoma and its prognosis. 120 years ago, in 1900s, we had 98% mortality, hardly any survival, and the only modality of management then was enucleation. Then came external beam radiation, which improved the prognosis. But then what has really revolutionized the prognosis is intravenous and intraarterial chemotherapy and eye salvage by intravitreal chemotherapy. Now we have more than 98% life salvage. That's a revolution that has happened in the management of retinoblastoma like no other malignancy anywhere else in the body. Clinical manifestations are fairly straightforward. In our series of about 2,800 patients, leukocoria was the most common presenting symptom as well as sign. When a child is detected to have leukocoria by parents or grandparents, children are often brought to the ophthalmologist or to pediatricians, and we are able to pick up retinoblastoma. But it's also important to realize that when the child has leukocoria, the tumor is already large. It's filling more than 50% of the ocular volume in a majority of patients with leukocoria, unless it's a macular tumor in an infant, where a small tumor can also manifest with leukocoria. So leukocoria generally means that the child already has group D or E disease. This is how a child with group D or E disease presents with very glaring unilateral or bilateral leukocoria. Now, squint as a symptom is a very high incidence, especially in India. In Western data, you find squint to be about 15 to 30% depending on the country. But in India, it's about 1/4 of children that present with squint. That means they don't have leukocoria, but they present with squint, either with esotropia, which is more common, or exotropia, depending on the location of the tumor and age of onset of visual deprivation. But squint being one of the most common symptoms, we should make sure that we look at the fundus of a child who presents to you with strabismus and not assume that it is either because of refractive error or accommodative esotropia. So fundus evaluation is mandatory in every child who manifests to an ophthalmologist with strabismus. Now, decreased vision could be because of a macular tumor, where the child may present with inability to fix or follow light or inability to recognize parental face. Redness is a late manifestation. When the child has redness in the eye, that means that the tumor is already filling almost the entire eye. Causes for redness are two. One is that the child may have secondary glaucoma or neovascular glaucoma, because of which the eye may become red. Second would be inflammation. Inflammation is produced by a necrotic tumor. Retinoblastoma is a round cell tumor. Round cell tumors grow so rapidly that they're deprived of blood supply. Part of the tumor may die, because of which there will be sterile inflammation that produces congestion and also chemosis. So red eye means it's a bad sign. This is fortunately become very rare in most of the parts of the country, except perhaps in some parts of northern India, where the child manifests with a bad orbital retinoblastoma. Now, diagnosis is very, very simple. Retinoblastoma is one of the easiest diseases to diagnose because you have a child who has a disease that is staring at you, begging for a diagnosis. Child manifests with leukocoria. All that you need to do is a good indirect ophthalmoscopy with or without anesthesia, and you'll be able to see the tumor and diagnose. Unlike tumors in the orbit or say lung or even abdomen, where tumors can only be diagnosed by imaging, here is a situation where the tumor can be seen and diagnosed, and the best chance to diagnose would be by a good indirect ophthalmoscopy. Ultrasound B scan is done only when you suspect that the patient may have a retinoblastoma and you're looking for some evidence in terms of calcification, intraocular calcification, or when the media is not clear. CT scan is also done to look for calcification, but the neuroimaging of choice and the safest neuroimaging modality is MRI. MRI helps you diagnose choroidal invasion, optic nerve invasion, extraocular extension, and also trilateral retinoblastoma or pinealoblastoma in a child who has genetic predisposition. So we would prefer MRI for neuroimaging. And of course, there are some newer advances in terms of PET CT scan, liquid biopsy, etc., which I would touch upon. Now, the differential diagnoses are also more important. In Indian situation, these are the 5 top differential diagnoses for leukocoria. When a child has a corneal opacity or cataract, well, of course, you can call it leukocoria, but that's not classic leukocoria. These are the classic examples for leukocoria, which can be sometimes confused with retinoblastoma. In Coates disease, it is not actually leukocoria, it is xanthocoria. You find this golden yellow reflex, that is what you see on distant direct ophthalmoscopy, or when you go close to the eye, even with high magnification, slit lamp evaluation, you'll be able to notice this telangiectatic blood vessels. These blood vessels signify that the child may have Coates disease as opposed to retinoblastoma, whereas retinoblastoma reflex will be whitish or pale yellow, and the blood vessels are not so well spread. They are discrete large blood vessels, whereas here you have varying caliber of blood vessels coursing through the retina, and they're more intense in the periphery of the retina. That's why it is called peripheral retinal telangiectasia, which is Coates disease. Now, this is persistent hypoplastic primary vitreous, where the child will have relative microphthalmia in the eye with PHPV. The cornea may be smaller than the contralateral eye. Even by 0.5 millimeter or 1 millimeter, the cornea will be relatively smaller. And when you look at the eye carefully, you'll find a posterior polar or cataract basically, and also dragging of the ciliary processes. That is a very remarkable sign of persistent hypoplastic primary vitreous. The next differential diagnosis is toxocara. There are 2 types of toxocara. One is peripheral, which presents with this falciform fold. Desmoplasia or traction is a hallmark of toxocariasis, and that's how it presents for a peripheral granuloma, whereas retinoblastoma lies silent and does not produce this dragging. And if it's a posterior polar granuloma with toxocariasis, again, there will be what is called drag disc appearance. Because of desmoplastic activity, retina will be folded and dragged towards this granuloma, and the disc also appears partially dragged towards the granuloma. Drag disc appearance of posterior polar granuloma are typical of a macular toxocariasis, whereas a macular retinoblastoma simply lies silent like that. Now, the next differential diagnosis would be astrocytic hamartoma. There are 2 types of astrocytic hamartoma, non-calcified and calcified. The non-calcified variant actually obscures the retinal blood vessels. It's like a button placed on the retina. Obscuration of blood vessels is a characteristic of astrocytoma. Of course, the child may have manifestations of tuberous sclerosis. Whereas a calcified one is sometimes difficult to differentiate from a retinocytoma. So you have to be careful when you see a non-calcified variant of what looks like astrocytoma. Astrocytoma is generally not larger than about 2 to 3 millimeter. Giant astrocytomas are known, but most of the astrocytomas are small, and that is how they can be differentiated. The last differential diagnosis would be medulloepithelium of the ciliary body. Now, medulloepithelium is an embryonal tumor. So these children develop a ciliary body tumor very early in this phase of development, because of which zonules in that quadrant fail to develop. So there'll be what is called zonular coloboma, which manifests as lens coloboma. We call it lens coloboma, but it is actually the zonular coloboma, because of which the peripheral contour of the lens will be distorted like that. There are no zonules in this area, and that's because of the ciliary body tumor that is lying there. That is medulloepithelioma. Now going on to classification. Classification of retinoblastoma is done in two ways. One is grouping and the other one is staging. All classifications have to follow the logical sequence of evolution of retinoblastoma. They should be very simple and easy to recall. If you recall Rees-Ellsworth classification, or remember that was the classification that we used to use when I was a resident, it was such a laborious classification that nobody could remember. Not even a retinoblastoma specialist would remember Rees-Ellsworth classification offhand, and they would often refer to a chart on the wall to classify by Rees-Ellsworth. So it's a laborious classification. And also Rees-Ellsworth prognosticates the eye for radiotherapy. So it's no longer used, and we have the international grouping and international staging for retinoblastoma, which prognosticate eye salvage and life salvage respectively. So what is staging? Staging is always to prognosticate life salvage. It has nothing to do with eye salvage. Here, stage 0 is no enucleation has been performed. That means the child has been treated conservatively by any of the conservative measures. Stage 1 is enucleation has been performed and the tumor is completely resected. Now, who's going to tell us that the tumor is completely resected? It is the pathologist. So pathologist has a major role to play in the management of retinoblastoma. If you want to accurately stage a child, then you have to bring in the role of a pathologist. Stage 3 is enucleation with microscopic residual tumor, again detected on histopathology. Stage 3 is regional extension, either in the orbit or regional lymph nodes. So until stage 3, there is 90 to 95% life salvage. For sure, there is no doubt at all. Beyond stage 3, there is less than 5% life salvage. So this is the watershed zone. Between stage 3 and stage 4 is the watershed zone, and we have to make every effort to diagnose and manage retinoblastoma when the child is earlier than stage 4 at the level of stage 3. This is a simple international grouping of intraocular retinoblastoma. There are two variations, Philadelphia and San Francisco variation. But basically, either which you use, this is the gross way of classifying it. A small tumor or group A is a small tumor less than 3 millimeter in diameter. Very simple. Group B is a tumor of more than 3 millimeter in diameter, tumor in the macular location, tumor near the fovea or juxtapapillary location less than or equal to 1.5 millimeter. So group B is a tumor which is larger, that is more than 3 millimeter, which is in the macular area or juxtapapillary location. Also a tumor with subretinal fluid. So all these attributes make it group B. Group C is easy to remember. C is for contained or confined subretinal seeds that happen in an exophytic retinoblastoma, or vitreous seeds that happen in an endophytic retinoblastoma. So C is for contained or confined or focal. Focal subretinal seeds or focal vitreous seeds make it group C. Remember D as diffuse. Diffuse subretinal seeds and diffuse vitreous seeds make it group D. Remember E as potentially enucleabilized with the tumor filling more than 50% of the eye volume, neovascular glaucoma, secondary glaucoma, anterior chamber infiltration, hyphema, or vitreous hemorrhage. So every character that actually prompts you to perform primary enucleation is group E retinoblastoma. This is the international grouping of intraocular retinoblastoma. Sometimes in fact, it is asked many times in DNB, a main question on the classification of retinoblastoma and newer advances. The two classifications that I mentioned earlier are slightly old, and what is new is the TNM classification. AJCC 8 is the latest TNM classification. It is revised every now and then, and this is what we have currently. TNM is tumor node metastasis, we all know it. But for retinoblastoma, a new alphabet has been added, that is H. It is TNM-H only for retinoblastoma, not for any other malignancy. H is for heritable trait. So what does it mean? That means that genetics is really in the forefront in the diagnosis, screening, and management of retinoblastoma. So for retinoblastoma, we call it TNM-H. Going straight to the management next. Now, management has been a success story in the West, we realize, but in India, we are catching up very fast. So goals of management, if somebody asks you what are the goals of managing retinoblastoma, you cannot say eye salvage. You always have to start with life. Primary goal of managing any malignancy is life salvage. If that is possible, organ or eye salvage is a secondary goal, and the tertiary goal is function, that is optimal residual vision. So we always have to go by these three goals. In a child where life is at stake, we cannot concentrate our efforts on eye salvage. That would be superfluous. There are many management options in retinoblastoma, which we simply classify as focal, local, and systemic. Let's go through these one by one. If you have a small tumor, say tumor of 3 to 4 millimeter in diameter or 3 to 4 millimeter in thickness, that is a small tumor. That does not have any implication on eye salvage because you can save an eye with a small tumor. That does not have any implication on life salvage as well. So in a small tumor, life is guaranteed, eye salvage is guaranteed. So what do you do next? You have to maximize vision. When you have a 3 millimeter size tumor, you cannot say that I cannot give back vision to the child. You can pretty well do that unless the tumor is in the foveal location. So how do you do that? You use focal therapeutic measures which are least damaging to the eye and vision. Cryotherapy is very good. Cryo is highly successful, more than 90% success. 1 to 3 sessions of cryo is performed. But the way to do cryotherapy is heavy triple freeze thaw cryotherapy. Now you can see this example. This is the tumor that we began with, 3 to 4 millimeter size tumor, and look at the scar, how huge it is. So cryotherapy always produces a very large scar. Not just the tumor, but the surrounding retina is also damaged by cryotherapy, because of which the scar is very large. Now this is okay on the nasal side, but what if a tumor is located just anterior to the equator, between the aura and equator, where you do heavy cryotherapy? You have a high risk of epiretinal membrane formation, you have a risk of dragging of the macula fovea, thus precluding 20/20 N6 vision. So cryo is useful, but it is not very extensively used unless it is really indicated. Cryo also produces atrophic retinal holes and rhegmatogenous retinal detachment as complications. So cryo is useful, but not extensively used. This is how we do cryotherapy. This is a common question. The way to do cryotherapy is triple freeze thaw cryotherapy. The tumor is frozen thrice and defrozen thrice. And thawing is always spontaneous. You don't accelerate thawing by squirting saline on the ice probe, a cryo probe. You always thaw it spontaneously. So if this is the 3 millimeter tip cryo probe, the tumor is elevated on top of it by indenting the sclera. It is centered and the foot switch is pressed. And the end point is complete freezing of the tumor and the vitreous, which is just anterior to the tumor. That is a very heavy cryotherapy that we do, triple freeze thaw. And the damage happens to the cellular components at the level of thawing, not at freezing. So thawing is very spontaneous and important. The next focal modality is photocoagulation. Photocoagulation was and is still very popular in many centers. The principle of photocoagulation is cutting off the blood supply to the tumor. So how do we do that? By surrounding the tumor with large diameter laser buns, not one row, but 2 rows of confluent laser buns. So that is very heavy laser. So you start with a tumor like this and look at the diameter of the scar. So large, obviously, correct? So the scar is going to be much larger with laser photocoagulation. You cannot do laser photocoagulation on top of the tumor because that will damage the internal limiting membrane of the retina and predispose the child to develop vitreous seeds. So you don't laser on top of the tumor, you laser around it, and that is the reason why you get a large scar. And obviously blood vessels that pass through that area become coagulated. So you have a higher chance of having small vessel occlusion. And if the tumor were to be closer to the optic disc, you would have a visual field defect for sure. Example, if you have a tumor which is, say, in the superior juxtapapillary area, and if you have photocoagulated it, be sure that the child will develop inferior arcuate scotoma. There is no doubt at all. It also reduces chemotherapy uptake if you're doing photocoagulation when the child is on chemotherapy, because you're coagulating the blood vessels and there is no way chemo will get into the tumor. So these are the issues with photocoagulation. So it is no longer used, and what is currently used is transpupillary thermotherapy. So if somebody asks you what is the current standard of care in focal therapy, your answer should be transpupillary thermotherapy. And the laser that is used for transpupillary thermotherapy is semiconductor diode laser. It is used with indirect delivery system, indirect ophthalmoscope delivery system. The spot size is large, 1300 micron. So spot is almost as large as the optic disc. So this particular tumor can be covered with 3 to 4 spots. That is it. It's a very quick procedure. And TTT works by not photocoagulation, but by increasing intratumoral temperature to about 45 to 60 degrees centigrade, thus inducing what is called tumor cell apoptosis. So it's a very gentle way of treating the tumor. And the scar is never going to be larger than the tumor that you began with, because in TTT, the principle is to do it on top of the tumor, not around it. And the blood vessels that pass through the area are classically patent. So TTT is least damaging to vision because it produces a small scar, a gentle scar, and does not cause vascular occlusion. You can see that we have TTT, this particular lesion, how close it is to the fovea macula, and there is no sign of any desmoplasia at all, no dragging, no folds in the retina, no ERM. So TTT is the best form of treatment for focal tumors. Now, what is new about TTT is photodynamic TTT or ICG enhanced TTT. Indocyanine green is a dye used for ICG angiography. The same dye will be injected in the child intravenously, and immediately thereafter you do TTT right on top of a tumor. You do it only in patients where there is a amelanotic scar. For example, this child had a scar already, regressed tumor, and between the disc and the scar, a new tumor developed at the edge. There was an edge recurrence in this child. Now, of course, you can do TTT, regular TTT, but the uptake will be less because there is no melanotic or a pigmented background to this tumor. And you enhance the effect of TTT by injecting ICG, and that's what was done in this patient with good results. Now, the conclusion for focal therapy is that less is more is the belief. That means lesser you do, better it is in terms of prognostication for vision. TTT has taken over completely, and photodynamic TTT is a good option. The next option is local therapy. In local therapy, the challenge is to optimize the eye salvage and vision salvage. The modality that we have for local therapy is plaque brachytherapy. Plaque is not used primarily unless there is a contraindication to chemotherapy. It is always used as a secondary measure. That means you have done chemotherapy and it has failed, or after chemotherapy the child has had a recurrence, then you use plaque brachytherapy. Commonly uses iodine 125 or ruthenium 106. The dose is 4000 to 4500 centigrade. Plaque is also very highly successful, 90% success in tumor control. Newer advances in plaque brachytherapy are the design. Notch plaque sits around the optic disc, and we're able to treat juxtapapillary tumors. It's a simple surgical process. Now, this is how a notch plaque works. This is a child with thalassemia major, could not be given chemotherapy because of systemic contraindications, was treated with primary plaque brachytherapy. You can see that the optic disc is nice and healthy, and the tumor is completely calcified. So this is the effect of a good, well-designed plaque brachytherapy. This is also a patient where there was recurrent retinoblastoma that was also treated with plaque brachytherapy. Plaque brachytherapy is very useful, but in secondary situations. This is the new Indian PRC plaque. Now, about external beam radiation, we don't use it anymore. It is no longer used unless as an adjuvant measure, mainly because it has suboptimal success and also because of the host of complications that it produces. Many of these complications are reversible, but what is not reversible is second malignant neoplasm. Radiation has risk of producing second malignant neoplasm in more than a third of patients who have undergone radiation if it's a heritable tumor in a young child. 1/3 is a huge number, and that is the reason why we avoid external beam radiation in retinoblastoma. Now, this is the watershed zone in the management of retinoblastoma, November 1996. Archives of Ophthalmology or JAMA Ophthalmology had a set of 4 articles. Generally, on a particular topic, you find one article, and any other contribution is found repetitive, and the editor tends to reject it. But here, the editor thought very uniquely and thought that these 4 articles needed to see the light of the day because all these referred to a new modality of managing retinoblastoma, that is chemotherapy. 4 groups in different parts of the world got the idea similarly at the same time, and all of them worked, and they submitted to the same journal, fortunately, and all of them got published, and that talked about chemotherapy in retinoblastoma. Further than that, there are a lot of advances, but this was the watershed zone. Chemotherapy is like going back in time. It was a paradigm change. How does it how do we refer to going back in time? Because it is the only modality that can actually reduce the size of the tumor. All other modalities treat the tumor, but here is a modality which can actually shrink the tumor. Now we have intravenous chemotherapy, standard chemotherapy. That is how we began in 1996. Now we have all these newer advances: high-dose chemotherapy, neoadjuvant chemotherapy, adjuvant chemotherapy, intraarterial, periocular, and intraocular chemotherapy. So chemotherapy has really evolved over the last 20 years or so. The drugs that are used for chemotherapy are carboplatin, etoposide, and vincristine. So this question may be asked, what are the drugs that are used? Carboplatin, etoposide, and vincristine. This is used for intravenous chemotherapy, given every 3 to 4 weekly, given for 6 cycles, and you're bound to perform EUA before each cycle and provide focal therapy as well. How does it work? It works in 3 ways. One is it reduces the size of the tumor. You can see this larger tumor and this larger tumor have become much smaller in size, and that maximizes vision because it exposes the fovea very early in the course of treatment. The second way that chemotherapy works is that it helps shrink the tumor, and the tumor moves away from the fovea macula if it's a posterior polar tumor and moves towards its source of blood supply. You can see that happening here. This is the primary manifestation before treatment. You can see that the tumor is abutting on the fovea. After 1 cycle of chemotherapy, tumor has evidently become smaller, and it has left the fovea and it has moved towards its source of blood supply, that is the supratemporal arcade. After 3 cycles of chemotherapy, tumor is nowhere near the fovea. It has moved towards the source of blood supply, that is supratemporal arcade. You can see that the caliber of the arcade has also become normalized. That means that the tumor is not receiving the kind of blood supply that it was earlier receiving. It's on its way to regression. So this maximizes vision because most of the posterior polar tumors will occupy or will be very close to the macula, and having them regress away from the macula is a gain for the child. This is one more example where the fovea is totally obscured, and following completion of treatment, fovea is totally clear. The next way of the way chemotherapy works is that it reduces SRF or subretinal fluid. Exudative RD settles down, thus maximizing vision. So it shrinks the tumor regresses towards its source of vascularity, and exudative retinal detachment settles down. That's how the child benefits with chemotherapy. It is the standard of care. It was the standard of care in early 2000s in the rest of the world. In India, it is still the standard of care, mainly because many of our families cannot afford intraarterial chemotherapy. Intravenous chemotherapy is inexpensive. It is available throughout the country, and it is still the standard of care. High-dose intravenous chemotherapy is something that can be used for advanced retinoblastoma. I will skip that. But what is new is intraarterial chemotherapy. Intraarterial chemotherapy has become the standard of care in the rest of the world. So if somebody asks you what is the standard of care for retinoblastoma, that is intraarterial chemotherapy for group D and D. Here the ophthalmic artery is catheterized by an interventional neuroradiologist, after which we take over and inject the drugs right into the ophthalmic artery. Now, what is the drug of choice? It may come as a MCQ. The drug of choice for intraarterial chemotherapy is melphalan. That is the drug of choice. In addition, you can use topotecan and carboplatin. So we use what is called a triple drug intraarterial chemotherapy, mainly to reduce the number of cycles and also increase the potency of chemotherapy. This is a situation where there is total bullous retinal detachment. After intraarterial chemotherapy, it's completely gone and the tumor is calcified. Again, a total bullous retinal detachment, completely calcified tumor. So chemotherapy intraarterial works very well on advanced retinoblastoma. One more situation, you can see large tumor completely resolved following intraarterial chemotherapy, macula is healthy. This is universally seen. In fact, intraarterial chemotherapy has the highest chance of eye salvage for group D and E retinoblastoma, and also it is useful for recurrent tumors. And about the technological issues, there are hardly any. In the last 100 consecutive sessions in our setting, we had 98% cannulation rate. Only 2 were ballooned. That's only because there was abnormal anatomy of the ophthalmic artery, or its ostium was narrow, they could not cannulate it. So it's a high success rate technologically. But the only thing that holds us back from using it in every patient is the cost. And how does it help? For group A, B, C retinoblastoma, it is as effective as intravenous chemotherapy, nearly 100%. But group D and E, it makes a huge difference. In D, there's a higher eye salvage rate of about 15%, and in E, there's a higher eye salvage rate of about 10% as compared to intravenous chemotherapy. So it's specifically useful in advanced tumors. So next part is about vitreous seeds. Vitreous seeds were the major barrier in the management of retinoblastoma because they were very difficult to treat. There are two ways vitreous seeds form. One is that there is a break in the internal limiting membrane and vitreous seeds proliferate. Second is the endophytic tumor can sprout like this. So either which way, there has to be a breach in the internal limiting membrane for the vitreous seeds to form. Once they form, they have two ways of growing. One is adherence independent growth. That means that they don't need a retinal substrate to get their nutrition. So they can be dispersed in the vitreous cavity and still grow. They cause what is called free floating spheres. If they are of the clonal type of adherence dependent growth, that means that they need a retinal substrate. That means that they have to settle down on the surface of the retina to get nutrition. So they form what is called epiretinal seeds. So after all this, we have been able to classify these seeds into all these subtypes. Earlier, we called them vitreous seeds. Now we have a term called classic vitreous seeds, but we don't call them vitreous seeds generically. We call them intraocular seeds. The classic vitreous seeds are found right in the retina. Then, depending on their plane, they can be prehyaloid, subhyaloid, epiretinal, intraretinal, subretinal. These are all the posterior segment seeds. Now, in the anterior segment, we have intracameral seeds. That means they are in the anterior chamber. There are two types of intracameral seeds. One are depository. That means that the vitreous seeds simply can walk through the zonules and come into the anterior chamber. Those are depository intracameral seeds. Vitreous seeds can infiltrate the ciliary body and the iris and come into the anterior chamber. They're called infiltrative anterior chamber seeds. All these are very important to recognize because that is how you prognosticate. These are prehyaloid, subhyaloid, intraretinal and subretinal. These are anterior chamber seeds, which are depository, and this is anterior chamber seed, which is infiltrative. You can see that the iris has become, pupil has become squarish. That's one of the telltale signs of iris infiltration in retinoblastoma. You can also see tumor in the anterior chamber angle. Now, morphological classification of vitreous seeds was also new. We have dust, the way it appears, dust-like seeds. We have cloud, it obscures the retina, and there is confluent whitish organized sheet of cells. Sphere, this is a sphere. And of course, there is what is called mixed configuration, where is a bit of this and bit of that. Now, how do we treat vitreous seeds? When the tumor is active or viable, you don't aim to treat vitreous seeds separately. You treat the entire eye, that is tumor plus the vitreous seeds. Then you do what is called intravenous or intraarterial chemotherapy, and to augment the concentration of the drug in the vitreous cavity, you give periocular chemotherapy. So the drug of choice for periocular chemotherapy is topotecan. So you inject topotecan around the eye along with intravenous or intraarterial chemotherapy when the child has tumor plus vitreous seeds. When the tumor has nearly totally resolved and all that is left is vitreous seeds majorly, then you do intravitreal chemotherapy. Now, intravitreal chemotherapy is given right within the eye and it has to be safety enhanced. So, what is safety enhanced intravitreal chemotherapy? The ideal criteria is that the retinal tumor should not be large. Use a site which is diametrically opposite to the location of the vitreous seeds. Suppose the vitreous seeds are at 3 o'clock, you go from the 9 o'clock. You always exit through eyes. That means if you have done a puncture here to enter into the eye. You apply a cryoprobe right next to it. Let the hub of the needle freeze within the cryoprobe. Then you withdraw the needle through the ice ball, and on top of that, freeze the same spot twice over. So it is triple freeze chemotherapy. Injection site cryotherapy is what it is called. Then there is also a concept called death by water. That means you pool the cul-de-sac with distilled water and let the extravasate tumor cells degenerate. And also you can raise a bleb of subconjunctival topotecan. These are all safety enhancement mechanism, out of which what is commonly done is this. We don't do death by water generally, and bleb is not raised. Again, someone may ask you, or in the exam you may be asked, what is the drug of choice for intravitreal chemotherapy? The drug of choice in the West is still melphalan. So you're not wrong in answering melphalan, but that is confined to the West. Why don't we use melphalan? Melphalan is very effective. As you can see, seeds go away very beautifully. But the problem with melphalan is that it is toxic to the retinal pigment epithelium, especially in pigmented eyes such as Asian Indians. It also produces more cataract and uveitis. You can see the effect of melphalan on the retinal pigment epithelium, which can affect vision. It can also cause vascular occlusion. So we don't use it commonly. We use topotecan. Topotecan is extremely effective and is also very gentle. The dose that is used is standard dose is 30 microgram. It is given 3 weekly. We also have a high dose protocol of using 60 microgram and 90 microgram. So if somebody asks you what is the dose of intravitreal topotecan, you'll be safe in saying 30 microgram is the dose given 3 weekly until the tumor regresses +1. Many a time you see the effect starting in 1 injection or 2 injections. Here is one example. Here's another example of 2 doses of intravitreal topotecan taking away the seeds. Seeds gone after a couple of injections. Large amount of seeds completely calcified. Seeds completely resolved. So these vitreous seeds resolve very beautifully with intravitreal topotecan. Sometimes use a combination therapy. One example, there's an active retinal tumor, bunch of vitreous seeds. After chemotherapy, retinal tumor has regressed, but the seeds are almost the same as we started off. After 6 injections of intravitreal topotecan, seeds are less, but they're still present. Then we added low-dose melphalan to it, and after that, seeds also went away. But you can see RP atrophy because of melphalan. So we have a what is called dual or combination therapy for intravitreal seeds. Initially, we found very good success with intravitreal topotecan in a selected group of 17 patients, but now we have hundreds of patients with intravitreal topotecan, and the effect is continuing to be good. Now, how do we classify regression pattern of vitreous seeds? Complete disappearance is called type 1. Conversion to calcified types or crystalline refringent dust is called type 1A or 1B. Amorphous non-spherical seeds, that means that the vitreous seeds become crenated and amorphous, don't confine to any known shape, it is called type 2. And the combination of 1 and 2 is called type 3. Extending indications for intravitreal injections are depository anterior chamber seeds. Now here is a situation where intravitreal or intracameral topotecan can take care of the anterior chamber seeds, which are gone here. One more example of anterior chamber seeds, completely gone with intracameral, that is in the anterior chamber we can inject topotecan 5 microgram. We also currently have what is called bicameral injection, where anterior chamber and posterior chamber both are injected by a safety enhanced technique. Now, we also use the same drug for epiretinal and intraretinal seeds. You can see all these seeds completely gone with intravitreal topotecan. Chemoplaque is something new, which is a drug delivery system. Now, the next bit is about enucleation. Enucleation, as you see in this slide, the trend is that enucleation is going down. In 1970s, 95% was the chance of primary enucleation, especially if it was unilateral retinoblastoma. Now it's gone to less than 30%. Standard indications for primary enucleation, any child with neovascular glaucoma or secondary glaucoma, any child with diffuse anterior segment infiltration, ciliary body infiltration, child with full chamber hyphema, vitreous hemorrhage, ophthalmus, or steroid inflammation. These are the situations where eye salvage is nearly zero, where you would be better off doing primary enucleation. Can we give chemotherapy before enucleation? You can give chemotherapy before enucleation in these situations where bilaterally the child has bilateral retinoblastoma where enucleating both the eyes may not be feasible. You can give neoadjuvant chemotherapy and see if any of the eyes could be saved. The second is parents are not ready for enucleation. Then again, you can give neoadjuvant chemotherapy to give them time to mount the eye. And the third indication would be when the child has a lot of inflammation like this because of sterile inflammation, endophthalmitis. This is sterile endophthalmitis where because of tumor necrosis, there is inflammation. Here you cannot enucleate safely because sclera is all inflamed and you may end up with a ruptured eye where we give neoadjuvant chemotherapy to make the eye atrophic or thiazical before we do a safe enucleation. Principles of enucleation, longer the better. Optic nerve stump more than 15 millimeter is good. This is a child with optic nerve involvement. If you were to stick to classic 10 millimeter, the child would still have optic nerve involvement, but extending the length by about 5 to 7 millimeter, we have a negative cut end that changes the prognosis. Second is that we should not have accidental perforation. Now, always use a primary orbital implant. This is a child with retinoblastoma where enucleation has been performed. Child looks good with a primary orbital implant and a custom ocular prosthesis. This is the least you can give for this child or the parents of the child because we have removed the eye, which goes against the principles of ophthalmology, but prognosis or improving the cosmesis is one of the goals of enucleation. Showing a video of enucleation for the residents. If you're asked to do enucleation, how do you do this particular technique called myoconjunctival technique and also get a long optic nerve stump. This is a unilateral advanced retinoblastoma in a 4-year-old child. Always do a small lateral canthotomy. This will give you more space to play with. 360-degree peritomy very close to the limbus using a blunt tipped conjunctival scissors. Always do enucleation under an operating microscope. The same microscope that you use for cataract surgery is good enough to do enucleation. You'll get a much better view, great illumination, and a good magnification. Dissect the posterior tenons already. Pass tagging sutures 40 silk through the insertion, just short of insertion of the extraocular muscle. Medial rectus first. One more tag suture with 60 vicryl, 6 to 8 millimeter distally, and disinsert the extraocular muscle in between the two sutures. Medial rectus followed by inferior rectus, lateral rectus, and superior rectus in the order of insertion of the extraocular muscles. Superior oblique and inferior oblique are simply tagged and disinserted. You don't simply disinserted, not tagged. Then you give a small relaxing incision that lateral conjunctiva, prolapse the eyeballs through the blades of the speculum that keeps the optic nerve in stretch. Enter with a blunt tipped 15-degree curved tenotomy scissor between the lateral rectus and the eyeball. Strum the optic nerve, hit the orbital apex, lift the scissor by 2 millimeter, and then give one bold cut to cut the optic nerve. Don't cut at the orbital apex then because you'll be cutting through the superior orbital fissure. Look at the optic nerve length, it is 19 millimeter. Without any effort, no enucleation spoon or scissors. Lift the posterior tenons up. Implant goes posterior to posterior tenons. Then you close the posterior tenons very meticulously because you don't want implant exposure or extrusion or migration. This is the first barrier. In myoconjunctival technique, you suture each of the extraocular muscles just short of the respective fornices. This tremendously improves the implant motility and the prosthesis motility as good as even a porous polyethylene or hydroxyapatite implant. So this is a very good technique to give better dynamic cosmesis. Then you suture the anterior tenons with 6 vicryl and finally suture the conjunctiva with continuous key pattern suture. At the end of the surgery, of course, you have to use a custom conformer, and finally at 6 weeks, you provide a custom ocular prosthesis. That's a conformer that is going in, and you always do a suture tarsorrhaphy there. So these are the steps of doing a enucleation with a long optic nerve stump, lateral canthotomy and relaxing incision. Make sure that all the extraocular muscles are transected completely. Use good traction sutures through the stumps of extraocular muscles so that you can hold the eye up, prolapse the eye, and use traction sutures for gentle direction of the eye. Avoid enucleation spoon and scissors. Use a 15-degree curved tenotomy scissors if you're doing from the lateral side, because the lateral orbital wall is at 45-degree angle. You have to use a 15-degree curved tenotomy scissor to reach there. Since the medial orbital wall is perpendicular to the lateral wall, if you come from the medial side, don't use a curved scissor, use a straight scissor because you can cut more posteriorly. If you use a curved scissor, you might end up somewhere there. Preferably lateral approach, that's what I prefer. Strum and cut just short of the apex of the orbit. Don't cut at the apex because then you'll be damaging structures that pass through superior orbital fissure, thus rendering no motility at all because you'll be cutting through the third nerve, fourth nerve, and sixth nerve. And in case of critical situations, bone cut is also okay. After enucleation, we'll look at the eyeball very carefully and mark all those areas for the pathologist to take sections from. And why do we do that? Because post-enucleation, the pathologist has to look for what are called histopathological risk factors. Now, histopathological risk factors are the prognosticators for life salvage. In 50% of Indian eyes, there are histopathological risk factors. These are iris and ciliary body involvement, angle involvement, ciliary body involvement, choroidal involvement more than 3 mm in thickness, more than 3 mm in diameter, optic nerve involvement beyond the lamina cribrosa, or optic nerve involvement to the transection. What happens if these histopathological risk factors are present? Then the child has a high chance of developing systemic metastasis, provided you don't give adjuvant therapy. So the current concept is every child with histopathological risk factors should get adjuvant chemotherapy, and every child with extraocular extension or optic nerve transection involvement should get external beam radiation as well. What happens if you don't do that? If you don't do that, then there is a 25% chance of child dying because of systemic metastasis. What happens if you do that? You reduce the chance of mortality to less than 4%. So it means that 20% of children are saved just by this one small measure of asking your pathologist to take sections appropriately, process the eye properly, report histopathological risk factors, and your oncologist to give adjuvant chemotherapy. Role has been established by a multicentric study. This is called Children's Oncology Group Study, which has unquestionably kind of established the role of adjuvant therapy. So enucleation is not the end in the management of retinoblastoma. We say it is just the beginning. Last part is about orbital retinoblastoma. Orbital retinoblastoma has varying incidence. Unfortunately, in India, it has come down quite a bit. It belongs to stage 3A of international staging, and in AJCC, it is CT4. There are 5 types of orbital retinoblastoma. Primary is when no treatment has been done and the child presents with an orbital disease. Secondary is when we have done enucleation and there is a recurrence. So primary can also be seen sometimes on MRI because clinically there is no evidence of proptosis. Secondary is when child has undergone enucleation and there is orbital recurrence. Accidental is when somebody does an intraocular surgery. Suppose a child presents with intraocular inflammation and you think it is endophthalmitis and you do a vitrectomy, then you have seeded the orbit with retinoblastoma, that is accidental. This child underwent hyphema drainage and trabeculectomy by a glaucoma specialist. When the child manifested with hyphema, 6 months later there was orbital retinoblastoma. So this is accidental retinoblastoma. Overt is when there is hidden extraocular extension which is not perceptible on imaging, and when you enucleate you find that there is extraocular extension. Microscopic is when the pathologist tells you that there is extrascleral extension, it may not be clinically evident, or optic nerve involvement to transection. This is a modality, this is a particular modality that's changed the management of orbital retinoblastoma. Is called multimodal treatment. Earlier, we would do orbital exenteration, that was the primary treatment of choice, which had 70% mortality. Now we do multimodal treatment. So what is multimodal treatment? We use 3 modalities in one child in a sequence, that is chemotherapy, neoadjuvant chemotherapy, high dose to shrink the orbital component, then surgery, that is enucleation, external beam radiation, and finally continued chemotherapy. So what is the sequence that we follow? We start with neoadjuvant chemotherapy for the orbital component of retinoblastoma. From this stage, the child goes into a comfortable phthisis. So eye becomes like this. Once we have radiologically monitored that the extraocular component is completely regressed, that is the time to do a enucleation with a long optic nerve stump. Then, of course, because the tumor was outside the confines of the eye, there would be microscopic residual seeded all in the orbit. So how do you treat that? You give external beam radiation. So once that is done, then the next course is adjuvant chemotherapy, because there will be microscopic metastasis in the systemic circulation. It is possible that the child may develop a systemic metastasis later, so that to prevent that, you give adjuvant chemotherapy as well. So it's a 1 year long treatment. It helps even in optic nerve invasion. See how thick the optic nerve is. It becomes normalized after neoadjuvant chemotherapy. Intracranial extension to cavernous sinus can also be treated, completely gone, and what is left at the superior orbital fissure is easily treatable. Eye has gone from this side to this, of course, ready for enucleation. And the bonus is that you don't have to do orbital exentration. This gross appearance in the initial manifestation can finally be reduced to this gentle, nice appearance of a custom ocular prosthesis, no exentration performed. Eyelid infiltration completely gone following multimodal treatment, and the child wears a custom ocular prosthesis. So no need for exentration. We hardly do exentration in retinoblastoma. So orbital RB also now has a cure. With all these components put together, currently in India with very cost-effective therapeutic measures, we have more than 95% life salvage. Of course, in advanced cases, it cannot be guaranteed, but at least in intraocular retinoblastoma, not orbital retinoblastoma, life salvage is expected to be about 95 to 98%. Chemo reduction or chemotherapy has overall 90% eye salvage. 95% of them whose eyes are saved have some vision, and depending on the location of the scar, children can have up to 20/20, 20/40 vision. More than 50% of patients where vision could be salvaged have good vision. There are, of course, socioeconomic barriers, but with a lot of effort, we have been able to reduce that to less than 10% abandonment in India. Future prospects, of course, we rely a lot on genetics, we rely a lot on early diagnosis, focal therapeutic measures, focal drug delivery systems, and advocacy. Now, there are apps to detect leukocoria. This is one particular app where parents can simply use the app, and that will actually differentiate normal red reflex from a leukochoric eye. This is a red reflex, this is a leukochoric reflex. The app is able to differentiate it. This is available both on Android and iOS. So in summary, I would say that life salvage has been made possible by chemotherapy, mainly neoadjuvant chemotherapy, adjuvant chemotherapy, and multimodal treatment. Eye salvage has been made mainly possible by intra-arterial chemotherapy, intravitreal chemotherapy, and brachytherapy. Of course, intravenous chemotherapy is the workhorse, but all these added together, we have 80 to 90% eye salvage. Vision salvage has been enhanced by intra-arterial and intravitreal chemotherapy, that too topotecan, and ICG enhanced ETT, we have 80 to 90% vision salvage. So in conclusion, group A tumors, focal therapy, where less is more, smaller the scar, the better it is. Group B, in a visually critical location, if the tumor is in the macular area, chemotherapy is the ideal initial treatment. After that, you do focal therapy. C, D, and good E, chemotherapy with local and focal therapy. Bad E, especially neovascular glaucoma, secondary glaucoma, ophthalmus, etc., enucleation primarily or secondarily with histopathology guided adjuvant therapy. Stage 2, where there is microscopic residual, adjuvant EBRT and chemotherapy. Stage 3, where there is orbital involvement or regional lymph node involvement, multimodal therapy. And stage 4, we generally tend to do palliative care. Well, in summary, I would say cost-effective and protocol-based management by a multidisciplinary team. So it needs an ocular oncologist, a pathologist, a geneticist, chemotherapy nurse. It's a whole lot of people. In fact, it said that it takes a village to treat a child with retinoblastoma. So that's your team that we have can help mirror eye and life salvage achieved in developed countries. Even in a country like India, where affordability is poor and children present late, we can achieve similar results with these techniques. Thank you so much.
Thank you, sir. Any questions from the residents or any doubts that you want to ask? Yes. Now,
Good
if you
evening,
do
sir.
not ask,
I'm Dr. Mohan.
Good morning.
Sir,
Can I
sir,
speak?
what is the
Yeah, go ahead.
sir, what is the recurrence rate after chemotherapy alone, sir? If tumor is intraocular only?
Yeah, see, if nobody does chemotherapy alone, we always combine chemotherapy with focal therapy. With chemotherapy and focal therapy, at least 30% of children will have recurrence, and recurrence can be treated. So
Sir,
with
recurrence,
6 cycles of chemotherapy and focal therapy, once you have achieved cure, at least 1/3 of children will have at least one recurrence minimum.
what is the treatment of recurrence then?
Recurrence,
Enucleus?
if it's a small recurrence, then you do transpupillary thermotherapy. If it's a peripheral recurrence, cryotherapy. If it is vitreous seeds, you do intravitreal chemotherapy. If it's a large tumor that is recurrent, then if you have used intravenous already, you shift to intraarterial chemotherapy. If you have used intraarterial already, you shift to intravenous chemotherapy. That's bridge chemotherapy. So you shift modalities. And if you have a medium-sized recurrence, less than 16 millimeter in diameter, less than 8 millimeter in thickness, you do plaque brachytherapy. So there are various treatment permutations and combinations which you kind of tailor to the child's needs.
Sir, when we consider enucleus on a recurrence,
Correct. If in a situation of recurrence, if you're already given enough chemotherapy and the child is poor systemic health, you cannot give more chemotherapy, or if there is no possibility of vision salvage at all, then you would consider enucleation.
thank you, sir.
Yes,
Hello, sir.
anybody else?
Good evening, ma'am. This is Dr. Mohan Raj, AIMS Patna.
Okay.
8 months old child. I will say the one's case scenario. Can you handle this, sir?
Yeah.
8 months old child come to you with the chief complaints. So some pediatricians referred to you.
Okay.
Right eye is normal, left eye is around 1.5 mm. People with the posterior side, 360 degree. In the USG, there is no calcification.
There is?
There is no calcification.
Okay.
Right eye is completely retina fundus examination normal. USG also normal. There is any idea, any other way, any other finding in the USG to we find this is retinoblastoma other than calcification?
Well, there will be a mass in retinoblastoma. So when you do USG B scan, you will find a mass in retinoblastoma along with calcification. If you don't find a mass, just detached retina or membranes with calcification, that is most likely Coats disease. In retinoblastoma, calcification has to be accompanied by a mass, and the calcification has to be intraocular, not in the Coats. Suppose there is an atrophic eye, then the calcification will be in the Coats, that is choroid. Right? That is dystrophic calcification. So that is not retinoblastoma. Anyway, so if in a situation that you describe, you say fundus cannot be seen and the pupil is small, there is posterior synechia bound on pupil, you cannot dilate, you cannot see the fundus. The reliable method of diagnosing then would be ultrasound B scan. And if it shows no mass and only calcification, it's unlikely to be retinoblastoma. You can be further sure by doing a CT scan. CT scan will pick up smaller areas of calcification. B scan is operator dependent. CT scan is done by a protocol. 1 or 2 millimeter cuts means 1 or 2 millimeter cuts. It scans the entire eye in various planes, axial as well as coronal. You can do sagittal reconstructions. The chance of picking up calcification will be higher on a CT scan. Still you have a diagnostic dilemma and parents are not ready for enucleation in that sightless eye. You can do MRI. MRI will be able to differentiate membranes, retinal detachment, blood from a tumor. If you still have any diagnostic dilemma, the last step would be a PET CT scan. PET CT scan has about 70% sensitivity and 80% specificity to diagnosing retinoblastoma, mainly by what is called uptake. So if SU max values are higher, that means that the tumor is metabolically active. That favors the diagnosis of retinoblastoma. Now, there are false positives also on PET scan, like a toxocara granuloma or endogenous endophthalmitis can be PET positive. That's a pseudo. Any inflammation can be PET positive. So there are situations where children have had PET positivity and enucleation has been done. I'm aware of those situations where final histopathology was a chronic endophthalmitis. Now, parents actually can get very upset with the diagnosis, but that is, you've done your best, right? You have got the best modality to screen the child, but still you may have a false positivity.
Sir, or a question, sir. In your experience, how many cases you saw calcification in the USGB scan without calcification? Finally, the diagnosis come to as retinoblastoma.
Right. So I haven't done an analysis. In fact, we are putting all our cases on the database, and I may be able to answer this question after about 3 or 4 months. But roughly, any child, younger child with retinoblastoma invariably has calcification. It's very rare to find a 3-year-old child or child younger than 3 years without calcification. Most of these patients will have intratumoral calcification. In an older child, so child closer to 5 years or 6 years or 7 years, older children with retinoblastoma are the ones who have peripheral tumors, acalcific retinoblastoma, and atypical manifestations. So any child who is older, calcification may be sparse or absent. Younger child, invariably the tumor will have calcification.
Thank you, sir.
Any of our panelists want to discuss something? Shafali, are you there?
Yes, ma'am.
Yeah.
Nothing to ask, but just a comment that whenever I listen to a lecture from sir, it's something new every time that I learn. So thank you so much, sir, for the lecture today. And thank you so much, Subudhi sir and Ajit sir and Pranav sir for this talk and session that you have arranged.
Would you like to discuss something with the residents?
For the residents, I think I would like to ask one question. Maybe I can shoot it to Ankita. Are you here?
Yeah, she's there.
Yes.
Ankita Mishra.
Ankita Mishra, yes. So just a simple question. If you have to choose an imaging modality for a child, as I was discussing right now, what would be your preferred imaging modality if you want to image a child of retinoblastoma, and why?
Ma'am, first one, I would try for the B scan to see any mass is present or not. Then I will prefer for the CT scan to see any calcification is there or not.
So, okay, I'll give you a leading question. Between CT scan and MRI, which would you prefer and why? In specifically in a child of retinoblastoma, like if you are suspecting retinoblastoma.
Ma'am, CT scan is for to find out any calcification, and MRI is a better option for children.
Okay, can you give me a few reasons why MRI is better? Okay, so I would go with MRI, but can you give me some reasons why MRI would be a better imaging modality?
As CT has radiation exposure and
so are these children prone to develop something with this radiation, or why would you comment on that?
It may aggravate the.
Any of the friends would want to help? Lakshmi, Dr. Lakshmi?
It causes, ma'am?
Yeah.
Ma'am, it causes radiation sarcoma
Yeah, so
after exposure to radiation.
Okay, and
This
any
is
other
Anjita.
reason why MRI would be preferable? Yeah, so these children are actually prone to develop secondary tumors. So definitely MRI, which has less radiation exposure, so it would be the modality of choice. And of course, it gives a better soft tissue density. So if you want to screen the optic nerve and other layers of the eye where the tumor can spread, so obviously MRI would be a better modality. Dr. Raghu, you would want to ask any other questions to the PGs?
Actually, yeah, I think Dr. SH has covered everything, almost all of it It was almost like a lesson for me as well, the big primer for me as well. So I can't think of any other questions that I can ask.
Voice is breaking.
Questions.
Yeah.
Something else to add?
It's not very clear, Dr. Raghu.
Hello, can you
Yeah,
hear me
now.
now?
Yeah, now we can.
Yeah. No, I don't have any more questions. If anybody else has anything more to add.
Chandana ma'am is here.
No.
Deepak sir. Dr. Deepak Mishra. Yeah, I want to ask some questions. Can I, sir?
Yeah, please.
Yeah, from your talk. Dr. Gurudev, can you tell what are the causes of redness and why redness is a bad sign, as said by sir? Unmute yourself.
He's not there online.
Please come on the video. Anybody can say, any resident can say.
Yes, ma'am.
We want to see the
ma'am.
resident's face also.
Yes.
He's there.
Yes, ma'am.
Yeah, please say what are the causes of redness as a
In
present.
case of yes, ma'am. In retinoblastoma, the redness may be due to the neovascular glaucoma.
Okay.
Or severe inflammation. Or
secondary glaucoma also.
Secondary glaucoma.
Okay.
And one more important thing was that the tumor necrosis within the tumor that can cause inflammation as well.
Ankita, what type of cryo is preferred?
Triple freeze thawing.
Okay. How triple freezing is done? Like what is complete freeze? Sir explained again and again.
It's first
okay, then how thawing is done?
At the site of the needle, the
probe.
No probe.
Do we have to pour saline or is it spontaneous?
Spontaneous.
Yes. Sir, can you please ask certain questions to the residents?
I think they're tired. No point. It's okay.
What is the dose of topotecan?
Yeah.
I just wrote it down. So, what is the dose of topotecan for
30 microgram.
use? I have noted a lot of notes actually from his presentation. What is the dose?
30 microgram, 3 weekly.
3 weekly, that's good. Melphalan, what is the safe dose? He has mentioned it. Actually, after 5 cycles of topotecan, he has given Melphalan.
He's very rarely come in the MCQ, but I've seen MCQs where drug of choice for intravitreal chemotherapy, the choices that were given included both topotecan and melphalan, so that is very confusing. Otherwise, if you have one of those, then you should choose that.
What is the intracameral dose for topotecan?
Not required for them, Ajit.
It's okay. Some examiner may ask them just to.
So 5 microgram.
Correct.
Yes.
Yes, very good, very good.
How many rows
So
of
I have
photopoint?
seen a lot of
Yes.
calcification post chemotherapy, which complicates the management of means any kind of secondary complications because of post treatment retinoblastoma. How do you envisage this in future? A lot of calcification I'm seeing. Yeah.
You're asking me, no?
Yeah, I'm asking you because.
Okay, so there is a concept called tylectomy. Tylectomy is a procedure where they do a VR surgery with melphalan infusion and remove the calcified mass. But that is dangerous. It is practiced in some parts of the world, like China, but the long-term results are not out. It is a procedure which has a lot of risk.
Mm.
You have done a lot of vitreoretinal surgeries in retinoplasty.
I know. That's why I'm asking.
But then we always do it when the tumor has regressed and has remained regressed for at least 6 months. That is how we do with
Yeah. We used to do 6 months
all
free.
no peritomy.
Yeah.
Sir, can I ask?
Can I ask one question? Oh, sir. Okay. Hello.
Yeah. Raghuraz, you can continue.
Yeah. With the case that you showed with the microscopic spread outside extension of the sclera. So do we go with the same like we treat it as an orbital retinoblastoma only?
Yeah, limited orbital retinoblastoma.
But the eye is already out.
Yeah.
So we suspect that there is still some micrometastasis within the orbit.
Microscopic spread is always there. It's a round cell tumor. Round cell tumors are very fragile tumors. Round cell tumors just spread. The seeds, like millions of cells will be there in the orbit, which will not be clinically evident. That has to be sterilized. So whenever there's an extraocular component, even full thickness scleral invasion means that there is a higher chance of orbital recurrence. So we have to sterilize the residual cells in the orbit by treating them. Enucleation will not help.
Yeah, anybody else?
I have one question, ma'am, to the sir.
Okay.
Yes,
Sir, what are the schemes? What are the schemes, national schemes? They protect this kind of low, poor children.
What is the
Because
scheme?
हमारे पास
There
कोई
are
कोई आ रहा है तो
Yeah. So there are NGOs. There are many NGOs in this field. One of which is called Can Kids. Can Kids Can. They are a nationwide NGO. They have presence in every part of the country. Some NGOs are regional, such as Iksha Foundation works mainly in the southern part of the country. They take care of retinoblastoma children very effectively. In fact, they support treatment, they support their travel, sometimes even they support their stay. So that is very useful. And least tapped source is this PM Relief Fund. In fact, there is a specific uh, provision in PM Relief Fund to give grant to cancer and children. So retinoblastoma is double, like it's cancer in children. So it has the highest chance of success. So what we have is we have an in-house social worker. His only job is to take care of parents with retinoblastoma. That is all he does, all through the day, all through the year. He just sits there, talks to all parents at every visit. Parents may come with some financial affordability initially, but as the treatment goes on and on, they may lose that capability to support treatment. So this social worker talks to them, and at any point in time, if they feel kind of a need for help, he applies on their behalf to CM Relief Fund or PM Relief Fund and make sure that the application is processed in a particular way and gets there. So it's easy for any institution to have this kind of a support system incorporated into management. Without it, there's a huge amount of abandonment. Once we incorporate all this, then the abandonment is really zero. In fact, Ajit, I know that 50% of children, 50 to 60% are treated absolutely free of charge. There's no charge at all. Even for VR surgeries that he used to do, he never used to charge. So even cataract surgery, if they have to undergo a cataract surgery, absolutely no charge. Thank you.
Subudhi sir, any questions, sir?
Sometimes we have seen some cases in the tribal population of our Odisha. Do you have any idea about that?
Tribal, well, I mean, it is not known to be kind of, more in any particular race, gender, or it is a universal disease. But, well, there are some pockets where it may be higher. We really don't know what is the reason because nobody has done genetics on these tribal children. I hear about that in some parts of Chhattisgarh also and Jharkhand. And in one part of Karnataka, coastal Karnataka, there is a tribe where it's supposed to be higher. And some parts of Gujarat as well, but we are really not sure what is the reason.
It's close. Yeah.
I think everyone got exhausted.
Really. So, some sort of really, it's a wonderful webinar today, and listening to Dr. Santosh is really a wonderful thing. And whenever we hear him in many lectures, any presentations, it really been just like a musical thing. So really, we have enjoyed your talk today. Thank you very much for giving us a very brief picture. You know, you have concised such a big talk in a very small way, and that of course it took more than 1 hour. So, but really, we never felt bored during this lecture. And I thank our moderator, Dr. Sarmishta, to bring out the right thing from the students, and Dr. Sefali, Dr. Navraj, and all the panelists. Definitely, they've done a great role. I thank our president, Dr. Pranav Ranjanji, and brother. I don't want to give him farewell this time because it's his last webinar with us with EIZOC ORTS. Maybe next time we'll become the immediate past presidents. And thank you, sir, staying with us all the webinars. I think all the more than 20 webinars you were with us continuously from starting to end. Last but not the least, my thank goes to our mentor, Dr. Ajit Babu, selecting very good speakers and very good topics. Thank you very much. And let us continue this talk for the post-year students. Definitely they are benefited. And I don't think today's talk is really wonderful for the students. They must have learned a lot of things. I thank some of the students who answered very well and also put the questions to the panelist and the speaker. So thank you all for joining with us. And last but not the least, our hosts, Enter Pharmaceuticals, who are provide the platform every time. So thanks, Mr. Rahul, representing them. Thank you all. Good night.
Good night.
Good night. Thank you, everyone. And it's always a pleasure listening to Dr. Santosh Hanawar. And thanks to the entire team of ORTS, including Dr. Subudhi, Dr. Ajit Babu Mati, Dr. Samishta Behr, and all of you. So this is probably my last presence as
you
a
are giving vote of thanks as a president.
Yeah, thank you so much. Thank you so much.
Yeah, we want to have you even in future.
No, I'll always. It has been continuously in EIZOC. I have been there for last 6 years as a secretary and then president-elect. So it has been a continuous journey, and I have thoroughly enjoyed it. Thank you so much. And thank you, Dr. Santosh, for taking time out for EIZOC. Thank you so much.
Thank you.
1.5 hours. I know. Thank you, Dr. Santosh, giving us 1.5 hours today. You know, it's such a busy person. Huh? And welcome for the next webinar in December. We'll have one more webinar team next month.
Sure, sir.
Yes.
Thank you. Good night.
Good night. Good night. Thank you, Santosh.
Thank you, Dr. Shefali. Thank you, all of you.
Yeah.
Thank you. Thank you very much.
Rahulji, you can close now.
Rahul hai ya nahi?
Rahul सोने चला गया. Good night, Rahul.
Right. Good night, everyone.
Good night, sir. Ajit Babu, sir, we'll miss you.
Good night.
Yes, sir. May I end the meeting, sir?
Yeah. You can close.